in the coming 15 to 20 minutes, I'm going to discuss a case that I met a couple of weeks ago with a false positive lung point with the explanation. So it's one of the most interesting cases you may find, but you need to know what's behind. So I have nothing to disclose in relation to this lecture. So 23 years back, Prof. Daniel Lichtenstein and his team had lung point sensitivity and specificity published in the Intensive Care Medicine Journal. And I quoted this from his publication. The absence of lung sliding indicates an abnormality. That's the first thing here. Pneumothorax is the most common abnormality with the absence of lung sliding. That's as per what is quoted from this article. Number two, absence of lung sliding is a sensitive but not specific for pneumothorax. So we are talking now about lung sliding. So the new sign, which was created 23 years ago, is the lung point, which can help to confirm a pneumothorax in the right clinical context. And please highlight in the right clinical context, because this is a part of what was prescribed 23 years back. So if there is no lung sliding is seen in one lung zone, the clinician should slide the probe inferior and lateral to look for the lung point. So absence of lung sliding is not diagnostic for pneumothorax. As per the lung point, you should be starting to slide your probe inferior and lateral to get the lung point. And once you get the lung point, now they quoted that it is pathognomonic for the pneumothorax. And this is the point of discussion tonight. This transition point between the pleural contact at the pneumothorax may be mimicked by other conditions. And that was what they said 23 years back, such as the presence of pleural blips. If you review all the case reports after this publication 23 years back, everyone is highlighting the pleural blips as the only and the main thing that may mimic the pneumothorax. But tonight we're going to discuss something completely different. So in this publication 23-year-old back, it says that the sensitivity of the lung point is 66% up to 75 in cases of radio occult pneumothorax alone. And that specificity is 100%. And here we need to go through some statistics to understand what is really sensitivity, what is really specificity, what is the positive and negative predictive values, and how we can use them. So this is a case of pneumothorax in the chest X-ray, just to explain what we're talking about. And the lung point is when you transit between the air, so there is no lung sliding here, to the normal lung in contact with the anterior chest wall. So you need to find where is the contact happening between the pneumothorax point and the healthy lung point. At the pneumothorax point, you find no lung sliding because the lung is pushed down by air. Now, if you find a transition zone where healthy lung tissue is there, where you have the lung sliding there, so this transition area between pneumothorax and healthy lung. So please remember with me, the lung point means by prescription of 23 years back by Daniel Lichtenstein, if I pronounce his name right, is again between a pneumothorax, which is pathological lung, and the healthy lung. And that was the mistake that we need to be aware of. It's not a mistake, but there is exception for every rule, and this is what we're discussing tonight. So pneumothorax is a transition that show still pleura with absent sliding. Healthy pleura will show lung sliding. So this is the blue protocol, which I am sure that 100% of people sitting in front of you now, Ashraf and Hisham, are like aware of this blue protocol. So the blue protocol says start by the lung sliding. When it is abolished, look for the A profile, and if the A prime profile, which is A profile but in a non-lung sliding, so you look for the lung point. If the lung point is there, you have a pneumothorax. That is the blue protocol 23 years ago. Okay, so let's talk about sensitivity and specificity. And I'm giving the pregnancy test because it's an easy example, and then we'll re-explain that on what is pneumothorax and lung point. So if we are discussing specificity, it's a test that should let's start by the sensitivity, which is easier. So sensitivity here is the true positive patients. If I have 10 patients have the disease, so all of them are pregnant for this test. So I have 10 patients, the 10 patients are pregnant, and the pregnancy test is positive. So the true positive here is 10 out of 10. So I can say sensitivity is now 100%, 10 out of 10. There's no false negatives. But if from the 10 pregnant ladies, you got 2 false negatives, this is when you say sensitivity of that test is about 80%, 8 divided by the total of true positive plus the false negatives. Okay, so if you divide the true positive by all the pregnant ladies, you get the sensitivity. So again, this is when you say this test is a strong positive, when you use the test to prove that this patient is pregnant. But now, if we're talking about ruling out the disease, or to say this patient is healthy, you need to divide, and this is what we're talking about, the specificity. So this is a male patient, so it's true negative. So I have 10 patients tested for pregnancy, and the 10 patients are negative. So you have no false positives. So your test is 100% specific. We need to understand that clearly here. But if I had done 10 pregnancy tests for 10 people, and you had 2 tests are actually positive out of these 10 tests, they can never be pregnant. So these 2 tests will reduce your specificity to 80%. So at this point, you divide the true negative by all non-pregnant patients. So specificity here is a test using the ability of this test to designate an individual who does not have disease, does not have this sign. Okay, so let's apply this to the positive predictive value. And this is a completely different entity. And this is where we should think of pitfalls of lung point. Positive predictive value, we are measuring the true positive divided by the all positives. And here, if I have 100 patients tested for pregnancy, and the 100 patients here are showing true positive and false positive, the false positive, they don't have pregnancy, they are males, for example. And this is 8, and this is 2. Now, the positive predictive value says that this test can show positive patients at 80%, while it can show as well false positive. So we need to talk, when we talk about true positive and false positive, we should talk positive predictive value of the test, not specificity at this example, because the specificity is designed to something else, to rule out the disease or to mark people as healthy. So in our example of pneumothorax, the same as the pregnancy test, true positive divided by the calculation or the summation of true positive and false positive is the positive predictive value. So in a nutshell, in this case, I found that the specificity as 100% is not pathognomonic, and this is what we have. So again, sensitivity 66 and specificity is 100% on the lung point. So this is the case, a 68-year-old gentleman in Dorset County Hospital with severe hypoxemia on a non-rebreathing face mask, 100% oxygen, and his saturation was 80s. Severe hypoxemia. He had a sore throat a couple of weeks ago. He started antimicrobials. He was on steroids for HLH. And then he's conscious but profoundly shocked with mottled skin. His systolic blood pressure was 60. So for sake of severe hypoxemia and profound shock, he was tubed and mechanically ventilated by myself. His airway pressure was extremely high, despite we ventilate him with 6 mL per kg of tidal volume and PEEP of 10. So the ED consultant at this stage had just grabbed the ultrasound machine. He did a quick point of care ultrasound, and he found a static pleura. And he said, okay, that's a pneumothorax. Airway pressures are high, patient is profoundly shocked, and now he's profoundly hypoxemic. So it's a pneumothorax. What supports his theory at this stage is the right side was completely diminished air entry by auscultation. So airway pressure is high. We thought right main stem intubation or left main stem intubation, and we re-examined our tube, so we pulled it a little bit backwards. So everything says it's a pneumothorax. Then I thought, okay, now if we think pneumothorax, we need to find the lung point. Let's examine for the lung point. And this is what is the ultrasound of these patients. So we found the lung point. If you see here, this is by the 2D. This is a mobile pleura. I hope you see that clearly as I see it on my laptop. Okay, so this is a moving pleura. This is a non-moving pleura. If you put the M mode here, this is a seizure sign, followed by, if I move the M mode to here, this is kind of a static pleura. So there was definitely, by this video, even without this seizure sign and barcode sign, a nice pleura as you see here. This is the lung point. There's a transition point of lung. But what is against that is when I examine the patient carefully, because at this stage ticks all the boxes. Just one sign against all of that made me not really convinced, which was percussion. With percussion, it was dullness on the right side, not hyperresonance. So I used myself to respect the hierarchy of seeing any patient. So history, clinical examination, investigations, including point of care ultrasound. So I cannot put the horse in front of the car. So there is lung point, there is a static and dynamic pleura, so it is 100% specific or pathognomonic for pneumothorax, but there is something suspicious in this case. If you compare this right to the left, this is seizure sign, barcode sign. Maybe the barcode sign was not the best in this scenario because the underlying lung was not healthy, and you will see why is that when you see the clinical context. So the only thing was percussion, and I'm highlighting that, please, if you consider pneumothorax, do the percussion before you put an intercostal drain. Then I thought to complete the lung exam with a curved probe on the lung. And what you see here on the left-hand side, this is the lung apex. And if you see here, this is the diaphragm is coming here. So this is the abdomen on the right-hand side. And this is the apex of the lung with a spine sign and complete hepatization of his right lung. Completely hepatinized lung. This is not the liver. I'll prove it to you in a minute. This is not a liver. This is his right lung. So hepatization here causes the static pleura here. But where is the dynamic pleura is coming from? I thought there is a good area of aeration towards the diaphragm in the right lower lobe of the lung. So this patient was going to do a pan CT to see if there is any other source of septic shock and other causes of his pneumonia and PE study as well. So he's going for CT anyway, but I was thinking during my way to the scanner, how is there is lung point, which should be pathognomonic, and it is not a pneumothorax. I aborted that intercostal drain looking at this curvilinear probe. It is just complete hepatization. And this is what we saw in the CT. You see on the right lung here, completely opacified right lung, while the left lung is aerated. That's why the airway pressure is high. That's why this patient is septic shock. That's what is the cause of severe hypoxemia. That explains everything. As you see here, we're going down, 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 down. And here we go. You see this aerated lung in the lower lung. So what is the difference between lung point here and lung point of pneumothorax? This is the diseased upper lung on the right side, causing you the static pleura because no aeration in the upper and middle loops. And when you go a little bit downward, this area aerated towards the abdomen is giving you some movement in the pleura. It is not the best seizure sign I know. It's not the best barcode sign I know because the underlying lung here is not that healthy. Still, it's affected by the pneumonia, but it is showing you 100% lung point. So my point is, if you talk about to rule in any sign, you need to look at the positive predictive value, because you need to look at the false positives as well, like our case. In case to say specificity here is 100%, you say the true negatives and the false positive. If you say the false positives is 0, you can say specificity is 100% and it's pathognomonic. But if we find this case as a false positive case, you cannot tell me anymore that specificity is 100%. If you don't agree with that, I'm more than happy to discuss it further. Again, sensitivity and specificity, you need to have the denominator here 0. No cases should be here. But I would be interested more in the positive predictive value to see the true positives and the false positives, and then you tell me about the positive predictive value of the test. In conclusion, diagnosis of a pneumothorax requires a complete assessment of all sonographic signs and all areas, not just the linear probe in front of the chest. Number 2, you need to consider the patient clinical presentation and put all your story together before you put the ultrasound probe. And if the story does not really fit, before you stick an intercostal drain in the patient's chest, consider, is there any blind spots? Is there anything missing in my exam I didn't do? Sorry, can you hear me? Can you hear me?
Just now.
Excellent. Excellent. So what I'm trying to say is, please put your examination and history as a part of the storytelling. If the story does not fit, you need to re-examine and revisit your story. The story needs really to fit. All parts of it need to fit to one scenario. I wouldn't miss that a chance. Without inviting you, please feel free to visit Saving Lives Academy and see our 2 previous conferences absolutely for free, 2020 and 2021, and for minimal payment for the 3rd conference in 2022. And there is a big surprise in the 4th conference coming soon, inshallah. So I would say history gives you the outline of your patient. Examination.
Thank you very much. Any question to Dr. Walid?